Now here's the study that was done in animals of exercise or mechanical loading. Smaller increases in bone mineral content and density, but huge increases in bone strength. So very small increases in bone density translate into very large improvements in strength. So I don't know that anybody has ever evaluated the mechanisms by which this occur, but the way I envision it in my head is that when you give someone a drug, it's going to bathe the entire skeleton. So it's going to improve regions of the skeleton that maybe aren't that important in determining your fracture risk. Whereas when you load your skeleton using exercise, now you're loading it, you're challenging it in a structurally and functionally appropriate manner. So it's only going to target the regions of the skeleton that are overloaded by that exercise. So I think of exercise as a more focused intervention to prevent fractures. So I said there were two ways that exercise could be better than drugs. The first way is what we just talked about, that we can potentially make bones stronger through exercise than through drug treatment. The second thing is that we know that exercise has other benefits that can reduce falls. So if we can make people fall less and make their bones stronger, then we should be reducing osteoporotic fractures through two separate mechanisms. So some new factors that are just being evaluated in animals have not yet made their way up to human studies. First one I think is probably most important. This was a study where all of the animals in the study were exposed to 360 loading cycles each day. They either got those all in one shot or they were divided into multiple sessions over the day. And what we're looking at on this axis is the bone formation rate response. So if you can divide up your exercise potentially into multiple sessions during the day instead of doing it just all in one session a day, potentially, we don't know this yet in humans, we will get better bone adaptations. So multiple exercise sessions may be better than one long exercise session. Taking vacations seems to be okay for bone. So this was a training study, again in animals, where one group was exercised for the first 5 weeks and then they took a 10-week vacation. Another group was 5 weeks on, 5 weeks off, 5 weeks back on. And the final group was exercised or loaded for all 15 weeks. So you can see the blue bars here. The group that took the 5-week vacation did as well, and maybe even a little bit better, than the group that had continuous exercise training or loading. So short vacations are okay. There are many, many factors in our bodies that can influence how our bones respond to exercise. So I want to talk to you a little bit about this one, PGE2 or prostaglandin E2, because it's an important focus of research in my laboratory right now. This prostaglandin E2 is essential for mechanotransduction. So when I create a force that acts on my skeleton, that force has to be translated into a biomechanical signal or a metabolic signal in bone. So we have these signaling factors, and this is one of the signaling factors that's important in bone. And PGE2 comes from something in your diet called arachidonic acid, and it gets converted through the action of this enzyme, cyclooxygenase. And the important thing about this is when you take ibuprofen or naproxen or any non-steroidal anti-inflammatory drug, that blocks the action of that enzyme. And we have reduced levels of all of these products of arachidonic acid. So the question is, if prostaglandin E2 is essential for generating bone formation responses, but yet taking NSAIDs causes a reduction in that, what does that mean about if you take NSAIDs before you exercise? Well, again, starting out in the animal literature, this is a study, again, we're looking at bone formation rate, where if the animals are treated with nothing, this is the bone formation response that is generated. If they were treated with this drug, which was experimental at the time, I think this might now be Celebrex. If they were treated with that drug 3 hours before mechanical stress was applied to their bone, they really didn't get much of a bone formation response. Even if they were treated with that drug 30 minutes before their loading, they had a 50% reduction in the bone formation response. But the good news is that if they were given this drug after their bones had been stressed, the bone formation response was pretty normal. So we did the first, and I think as of yet the only study to determine whether this is of any relevance to humans. So we conducted this study in young women. They came into our facility for an exercise training intervention that we expected to increase bone density. And on every day that they exercised, they took 2 study drugs. One group took placebo, which is, no active drug, before and after they exercised. One group took ibuprofen at 400 milligrams, the standard over-the-counter dose. They took that before they exercised and placebo after. And the third group took their ibuprofen after exercise. So our hypothesis was that the group that took ibuprofen before they exercised would have the least favorable improvements or the least favorable changes in bone density. So this red group is the group that took ibuprofen before exercise. And you can see with the exception of one site, they tended to have small decreases in bone mineral density. We thought that the group that took placebo before and after, the gold bars, would have the best response. In fact, they didn't have a very good response, although at some sites it tended to be better than the group that took ibuprofen before. The surprise to us was we thought that these 2 groups would be very similar because animals given ibuprofen after loading, they have the same response. So we thought these 2 groups would be pretty similar. But in fact, it was the group that took ibuprofen after they exercised that had the best responses. Now, I want to caution you that this is very preliminary. We're following this up with studies to confirm whether it's true, but we think that when you exercise vigorously, you increase some inflammatory response. That's a normal response to exercise, and that can actually trigger some bone resorption. So by taking an anti-inflammatory, you may actually be getting some benefit. But there are risks of taking these drugs also, so we would not recommend that you take them to get this benefit, at least not yet. One other novel factor that I want to talk about briefly is calcium is certainly not novel, but this hormone called parathyroid hormone. And let me ease into this gradually. We know that cyclists, as a group of athletes, tend to have low bone density. So this is cyclists compared to runners. And at a number of sites, cyclists have lower bone density. Even when we compare cyclists with non-athletes, with the average person, cyclists also sometimes appear to have low bone density. And the prevailing thought on this is that some athletes, such as cyclists and swimmers, have low bone density because they participate in weight-supported activities rather than weight-bearing activities. But my contention with this is the fact that these athletes have lower than normal bone density suggests that under some conditions, exercise may actually be causing bone loss. So exercise is not always a good thing, and let me try to convince you of that. We did, again, what I think is the first and only study to follow a group of cyclists prospectively through 1 year that included their 8 to 9 months of training and competition, sorry about that, and then their off season. And I'm just showing you changes in hip bone mineral density here, but they actually had decreases of the magnitude that we would expect to see in postmenopausal women. So they were definitely losing bone. Now, when we went to publish these data the first time, our reviewers said, that can't be, because then we'd have cyclists out there who would look like old ladies. They'd be osteoporotic. Well, there's one study of master cyclists that has been published. These were guys who had been cycling about 20 years. And their BMD levels are now reported as standardized scores, or T-scores. And a T-score of -1 is indicative of osteopenia. So that's like pre-osteoporosis. So they didn't look very good. And what we did was we took these data and we assumed that 20 years earlier, these men had had normal bone density, that they started out with a T-score of 0. And then we used our data on the rates of decline that we measured in our cyclists, and we predicted what the T-scores would be after 20 years of cycling if they had been losing bone at the rate that we measured. And look at the predicted values relative to the measured values. They're pretty darn close. So we think that the rates of bone loss that we're measuring in the cyclists that we've been studying are real. Why? Why would they be losing bone? I hope this isn't too in-depth for you, but I think it'll make sense to people. When you sweat, and if you're, let me back up. Cyclists and swimmers, as groups of athletes, are characterized by doing many hours per week of training. So they're sweating many hours per week. And when you sweat, we know that there's salt in sweat, but there's also calcium in sweat. So if you are exercising, and I don't care if it's cycling, swimming, running, whatever, soccer, if you're exercising many hours a week and you're sweating a lot, you're losing a lot of calcium. And the sweat, or the calcium that's in your sweat, is actually coming from the blood. So when you sweat a lot, you get a decrease in serum calcium levels. And calcium in your blood is very, very important. If it goes too low, you can die. So this is something that your body regulates very tightly. And if you get even a small decrease in your serum calcium level, you will get an increase in this hormone called PTH, parathyroid hormone. And the primary responsibility of this hormone is to go to the bone and to mobilize calcium from bone. So it increases the rate of bone resorption, and it does this within minutes so that calcium can be mobilized from your skeleton and come into the bloodstream to make sure that your blood calcium levels don't decrease any further. So our contention is that perhaps if this happens day after day in athletes who are sweating a lot, that this would eventually lead to a decrease in bone density. And we're doing many studies now to determine whether these mechanisms are true. We're also doing some intervention studies to determine whether, if you take supplemental calcium shortly before you exercise, and we think you probably have to do that about 2 hours before exercise to make sure that the calcium is down in the part of the gut where it can be absorbed into the bloodstream. But maybe if you can provide an alternate source of calcium, that you could prevent some of these downstream events from happening. So if you're going to take calcium, if you're taking supplemental calcium, and the news that hit the airwaves today about calcium and vitamin D might cause you to think about how much calcium and vitamin D you're taking. But if you take it, you might want to take it before you exercise because you might get some benefit from that. So let me sum up some of the science-based theory, the most important points.